Treatment of convulsive status epilepticus in children based on study by Becker et al. 2023. Status epilepticus, SE, refers to a prolonged clinical and/or electrographic seizure that does not cease within an expected time frame. SE is one of the most common, life-threatening neurological emergencies in childhood, with about 1723 episodes per 100,000 children annually, and with the highest incidence in the first 5 years of life. SE can result in neurologic morbidity and has an overall mortality rate of up to 3%. Most common SE etiologies in children are prolonged febrile seizures, sudden discontinuation of anti-seizure medication, ASM, in children with treated epilepsy, acute central nervous system, CNS insult, and chronic neurological conditions. The International League Against Epilepsy, ILAE, defined SE as a condition resulting either from the failure of the mechanism responsible for seizure termination or from the initiation of mechanisms which lead to abnormally prolonged seizures after time point T1. It is a condition that can have long-term consequences after time point T2, including neuronal death, neuronal injury, and alteration of neuronal networks, depending on the type and duration of seizures. The ILAE task force suggested treatment to be initiated at T1, and if T2 is reached, that treatment should be exacerbated to prevent long-term damage. They further delineated T1, that is, the time when a seizure is likely not to be self-limiting, to be 5 minutes in generalized tonic-clonic GTC-SE, 10 minutes in focal SE with impaired awareness, and 10-15 minutes in absence SE, although there is no data on the latter. Furthermore, they defined T2 to be 30 minutes for GTC-SE and 60 minutes for focal SE with impaired awareness. For other SE subtypes, including febrile seizure SE and focal SE with awareness, no duration has been proposed, leaving the older definition of 30 minutes. This earlier initiation and more aggressive therapeutic approach in the new IALAE definition is based on the knowledge that treatment becomes increasingly difficult the longer ASE lasts, in part due to receptor trafficking such as a reduction of GABA receptor-mediated inhibition. The correct choice of timing, dosage, and sequence of ASM is important, but the optimal pharmacologic treatment is largely unknown for the pediatric population, and most guidelines focus on adult patients. Only a few randomized controlled trials, RCT, exist for children that meet Class I evidence. Therefore, pharmaceutical management guidelines, such as the ILAE pocket card, often rely on expert opinions or experience with adult patients, giving rise to the need of controlled studies in pediatric patients and neonates. 2 studies identified that time until sufficient treatment is established is often prolonged, and if treatment is started, it is often not sufficiently high, partly due to out-of-hospital onset and intermittent SE. This calls for the establishment and distribution of guidelines, particularly for children, to aggressively address the treatment delay and to reduce putative permanent neuronal damage. General considerations: Phase 0, 5 minutes. Basic life support, airway, breathing, circulation disability needs to be addressed in every patient with a seizure. This includes monitoring of vital parameters, heart rate, and oxygen saturation. It is essential to start timing a seizure from the very beginning to intensify treatment appropriately. The seizure semiology details should be recorded and seizure type S determined. A detailed history about pre-existing conditions / comorbidities, including an epilepsy diagnosis or recurrent status epilepticus with previous or existing ASM dosages, should be conducted. An extended neurological exam should be performed as soon as possible to identify focal neurologic deficits and specific clinical signs that indicate a seizure Etiology. The initial workup can be initiated while establishing intravenous (IV) access and should include the analysis of blood gas, electrolytes, and glucose levels, a blood count, a toxicology screen, and ASM levels, if appropriate. If IV access cannot be obtained, intraosseous or central access should be pursued. An electroencephalogram, EEG, should be sought as early as possible. An EEG can help identify a focal seizure onset, clarify non-motor seizures or paroxysmal events under muscle-relaxing drugs, and monitor sedation. Cranial imaging studies using magnetic resonance imaging, MRI, or computer tomography, CT, need to be considered in every child with SE, particularly in children without previously history of epilepsy, brain surgery, and implanted shunt systems, or in those at risk of complications that might result in SE. Imaging can reveal tumors, inflammation, ischemia, cerebrospinal fluid, CSF, retention with herniation, and other possible patterns important for treatment initiation and ultimately outcome. Early phase treatment in the pre-hospital setting. Phase 1, more than 5 minutes. The first-line treatment for children with convulsive SE in the pre-hospital setting is a non-IV applied benzodiazepine. Available benzodiazepines are diazepam, rectal IV, midazolam, buccal, intramuscular, IM, intranasal, in, IV, and lorazepam, I4, in, buccal, without evidence for the best agent and application in children. Rectal diazepam is usually given at a dose of 0.20.5 milligrams per kilogram. Proposed doses 15 kilograms 5 milligrams, 15 kilograms 10 milligrams, maximum single dose 10 milligrams, maximum 2 doses. Diazepam is lipophilic and rapidly penetrates the blood-brain barrier, leading to onset within a few minutes, a maximum effect after 10-20 minutes, and a long half-life of 2100 EH. Buccal midazolam is given at 0.20.5 milligrams per kilogram. Proposed doses 3 months, 1 year 2.5 milligrams, 1 5 years 5 milligrams, 5 10 years 7.5 milligrams, 10 years 10 milligrams, maximum single dose 10 milligrams, maximum 2 doses, with a maximum effect expected after approximately 10 minutes and a shorter half-life than diazepam of 3,4-H. In a recent Cochrane review on drug management of children with GTCs, including convulsive SE, no evidence for efficacy between the latter two drugs was identified. Another meta-analysis on midazolam, lorazepam, and diazepam for the treatment of SE in children found a superior effect for non-IV midazolam, buccal, in, or IM, in comparison to non-IV diazepam. In conclusion, buccal midazolam has been reported to be at least as effective in cessation of SEE, equally safe, and also more socially acceptable than rectal diazepam. Buccal midazolam is also the most cost-effective drug in the United States. There is insufficient evidence to support the use of alternatives such as in or IM midazolam and in or buccal lorazepam to buccal midazolam or rectal diazepam in the pre-hospital setting. Previous studies, however, have suggested that in midazolam, 0.2 mg/kg/dose is more effective than rectal diazepam, 0.5 mg/kg/dose. McTague et al. Highlighted that in general buccal and in application of ASMs resulted in similar seizure cessation rates as IV-applied ASMs. The anticonvulsant effect of sublingual lorazepam has been reported to start with a delay of about 20 minutes after drug application, and this treatment is therefore inappropriate for acute SE treatment. Paraldehyde, IM rectal, is not recommended anymore due to less availability in clinics and also superiority of currently accepted treatments. Due the efficacy of buccal midazolam, the data on cost-effectiveness of midazolam and the ease of administration through the buccal routes, we propose to use buccal midazolam as the best option for prolonged seizures 5 minutes in a pre-hospital setting. Early phase treatment in the hospital setting, phase 2, 5-10 minutes. In most guidelines, the first drug treatment phase after stabilization of the patient in the emergency hospital setting is the administration of a benzodiazepine. The effect of benzodiazepines can decrease drastically as SE progresses due to GABA receptor internalization. Therefore, early treatment and sufficient dosage are essential. If benzodiazepines such as buccal midazolam or rectal diazepam have already been administered in the pre-hospital setting, care should be given not to overdose, that is, apply more than 2 doses, including the pre-hospital doses, and thereby exceeding the maximum dosage. An excess benzodiazepine exposure increases the risk of respiratory depression. There is still limited data regarding the possible superior effect of IV versus non-IV benzodiazepine administration, especially midazolam. In general, IV lorazepam, midazolam, and diazepam result in similar rates of seizure cessation and respiratory depression, but lead in some studies to more rapid seizure cessation than buccal midazolam or rectal diazepam. Another possible administration is IM midazolam. In the multicenter double-blind RCT Rampart trial, rapid anticonvulsant medication prior to arrival trial, IM midazolam, 1340 kilograms, 5 milligrams, was as effective as IV lorazepam, 1340 kilograms, 2 milligrams, in SE treatment in the pre-hospital setting in a mixed adult and pediatric cohort of 893 patients, including 120 children, 73% versus 63%. This result was not statistically significant when studying only the 120 children, and the prolonged time to achieve an IV line for the application of lorazepam needs to be considered. This result is supported by 2 further meta-analyses, including the Cochrane review with similar or better seizure cessation rate of IM midazolam than IV diazepam lorazepam. If an IV access has been obtained, IV lorazepam 0.1 mg/kg/dose, maximum single dose 4 milligrams, maximum 2 doses, IV diazepam 0.2-0.3 mg/kg/dose, maximum single dose 10 milligrams, maximum 2 doses, or IV midazolam 0.1 mg/kg/dose, maximum single dose 5 milligrams, should be considered. The effect of these drugs should be apparent rapidly within 0.5 minutes. There is insufficient evidence to favor either of these IV drugs with respect to seizure control. In addition, there is no clear significant difference between the SE cessation effect of IV's midazolam versus IV diazepam, IV midazolam versus IV lorazepam, or IV lorazepam versus combined IV diazepam phenytoin. However, a second dose to control seizures had to be applied less often if lorazepam was given compared to diazepam. No significant difference was seen when comparing the effect of midazolam versus lorazepam or diazepam versus midazolam. IV lorazepam has been associated with fewer adverse events such as respiratory depression, excessive somnolence, and sedation than IV diazepam. Favoring lorazepam as the first-line treatment over diazepam has been criticized recently due to limited data on a superior effect. If the seizure does not terminate 5 minutes following initial benzodiazepine administration, then a second benzodiazepine dose should be administered. An application of more than 2 consecutive doses of benzodiazepines, including any dose given in the pre-hospital setting, increases the risk of respiratory depression and is associated with sedation. In conclusion, we suggest applying IV lorazepam if IV access is available, given that it is at least as effective as or more effective than IV diazepam midazolam and has been suggested to have fewer side effects. If no IV access is available, buccal and especially IM midazolam are also acceptable first-line anticonvulsants for convulsive SE treatment in the hospital setting. Expanded treatment in the hospital setting, Phase 3, 10 minutes. When benzodiazepines fail to terminate a convulsive SE, non-benzodiazepine ASM such as phenytoin, fosphenytoin, and phenobarbital are applied. There are no RCTs comparing the voltage-gated sodium channel inhibitor fosphenytoin to the positive allosteric GABA receptor modulator phenobarbital in children, but fosphenytoin is usually preferred in pediatric SE treatment guidelines, except in neonates where phenobarbital is preferred, given its fewer cardiorespiratory depression side effects when compared to phenobarbital given after benzodiazepines. Phenobarbital can cause respiratory depression, hypertension, and bradycardia, and should thus be given only in an intensive care setting. When phenobarbital and fosphenytoin are used sequentially, fosphenytoin has been suggested to precede phenobarbital, especially when benzodiazepines have already been used on account of its better safety profile and the lower likelihood of cardiorespiratory depression. There is insufficient data about the comparative efficacy of phenytoin and fosphenytoin. However, fosphenytoin is better tolerated compared with phenytoin with respect to cardiac arrhythmias, blood pressure imbalance, and local skin reactions. Phenytoin and fosphenytoin are hepatic enzyme inducers and can subsequently lower other drug levels such as those of carbamazepine, oxcarbazepine, valproate, levetiracetam, lacosamide, lamotrigine, and topiramate. Despite fosphenytoin and phenytoin being contraindicated in the daily treatment of Dravet syndrome, there is currently no proven contraindication in the acute setting, though mostly other ASMs are applied. There is increasing evidence to support the use of alternatives to IV fosphenytoin and IV phenobarbital for treatment of pediatric convulsive SE, such as the off-label administration of levetiracetam, brivaracetam, valproic acid, and lacosamide. These drugs are frequently applied when registered treatment options fail. There is some evidence that there is no difference in whether these second-line ASMs are already in the patient's home medication or not. For levetiracetam, several RCTs have shown its benefit in treatment of pediatric convulsive SE despite not being approved for this application. In a recent trial, a superior effect of levetiracetam, 40 mg/kg/dose, over phenytoin, 20 mg/kg/dose, 93% versus 83%, in cessation of benzodiazepine refractory SE was demonstrated in a large cohort of 600 children, mean age 3-4 years. This superior effect could not be confirmed in the concept trial, convulsive status epilepticus pediatric trial. In the latter, 233 children, 3 months, 13 years, who presented to one of 13 emergency departments in Australia and New Zealand over a 2.5-year time period were treated with IV or intraosseous infusions of phenytoin, 20 mg/kg/dose, or levetiracetam, 40 mg/kg/dose. Clinical cessation of seizure activity 5 minutes after the end of the drug infusion occurred in 60% of patients in the phenytoin group and 50% of patients in the levetiracetam group. It needs to be noted, however, that the infusion times varied between the two groups, 20 minutes for phenytoin, 5 minutes for levetiracetam. Given that SE duration comes with more difficulties in controlling SE, this can be a bias. In the ECLIPSE trial, emergency treatment with levetiracetam of phenytoin in status epilepticus, 404 children, 6 months, 18 years, who presented with SE to one of 30 emergency departments in the UK over a 3-year time period were treated similarly to the concept with phenytoin, 20 mg/kg/dose, or levetiracetam 40 mg/kg/dose through IV or intraosseous infusions with differing infusion times. Deviating from the concept trial, the primary outcome was not seizure cessation 5 minutes after end of the drug infusion, but rather time from randomization to cessation of convulsive SE. Here, convulsive SE occurred in 64% of patients in the phenytoin group within a median time of 45 minutes and 70% of patients in the levetiracetam group within a median time of 35 minutes. The authors conclude that though no significant superiority of levetiracetam over phenytoin was identified, levetiracetam could be an appropriate alternative to phenytoin as the first-choice second-line ASM in the treatment of pediatric convulsive SE, given their data and the safety profiles of the drugs. In the most recent large double-blind RCT ESET, established status epilepticus treatment trial, the efficacy of fosphenytoin, 20 mg per kilogram, max 1,200 mg, valproate, 40 mg per kilogram, max 3,000 mg, and levetiracetam, 60 mg per kilogram, max 4,500 mg, in 225 children, 2 years, and 237 adults with benzodiazepine refractory convulsive SE were included. There was no difference in efficacy or safety in children between the three groups, with seizure ceasing within 1H with levetiracetam in 52%, with fosphenytoin in 49%, and with valproate in 52% of patients. Other studies also underlined the similar effect of levetiracetam in comparison to valproate and fosphenytoin, and it being well tolerated in general. In conclusion, levetiracetam is overall well tolerated with only low rates of increased aggressiveness, irritability, nausea, and vomiting. In our own hospital setting, off-label levetiracetam is an equally established drug to fosphenytoin in children given the low side effect profile. In adults, brivaracetam has been reported to be a safe alternative to levetiracetam to treat SE, but results of an ongoing RCT for children are not available yet, except for one study that includes pediatric cases with absence SE. Given the faster transition of the brain-blood barrier of brivaracetam versus levetiracetam, reaching maximum concentration in the brain within minutes following IV application, brivaracetam treatment is a promising approach. However, it is currently not approved for SC treatment. Sodium valproate, which modulates sodium and calcium channels and the metabolism of GABA, has been shown to be effective in treatment of pediatric convulsive SE and in adults to be superior in SE cessation, for example, than phenytoin. In a RCT on 100 children with diazepam refractory SE, valproic acid, 20 mg/kg/dose, and phenytoin, 20 mg/kg/dose, were similarly efficient in ceasing seizure activity with no significant difference in side effects. In a further RCT, IV valproic acid, 20 mg/kg/dose, was more effective in SE cessation, 90% versus 77% seizure cessation, and better tolerated, adverse effects 24% versus 74%, than IV phenobarbital, 20 mg/kg/dose, in 60 children younger than 2 years of age. Sodium valproate can be administered rapidly IV through an infusion pump with rare adverse effects such as hypertension, blood count drop, platelet dysfunction, hypersensitivity, acute hemorrhagic, pancreatitis, and hyperammonemia. A major concern is valproic acid hepatotoxicity, particularly in children who are under 2 years of age and who could have a metabolic mitochondrial disorder. Particularly, mutations in the DNA polymerase gamma gene, POLG, cannot be ruled out in the acute setting unless in-depth genetic testing has already been performed and results are readily available. Valproate is a strong hepatic enzyme inhibitor, and it may raise other drug levels, such as those of carbamazepine, lamotrigine, phenobarbital, and rufinamide, especially when combining with drugs favoring hyperammonemia, for example, phenobarbital. Clinicians should be concerned about valproate-induced hyperammonemic encephalopathy, a rare complication characterized by decreased consciousness, neurological deficits, and vomiting. Only a few studies focused on the effect of lacosamide in the treatment of pediatric SE, most likely due to the fact that lacosamide is licensed for children older than 4 years and focal onset seizures only, not for SE treatment, and the subsequent off-label use in younger children. A review on 6 retrospective studies, including 36 pediatric patients with various SE subtypes, showed an overall success rate of 45–78%, age range 1 month to 17 years, with doses between 4 to 10 mg/kg/dose. Of the 36 lacosamide-treated children, 1 had bradycardia and 2 had delayed oculogeric crisis and chorea. Otherwise, no serious side effects were reported. Since lacosamide can cause PRQT prolongation, it should be administered with electrocardiogram (ECG) monitoring. Lang et al. Recently reported a 70% cessation rate of seizure series, or SE, in a heterogeneous mixed pediatric and adult cohort of 119 patients who received additional lacosamide, median dose 300 mg, to the hospital's ASM protocol with a good tolerability. In a study with 196 adult and pediatric patients, lacosamide and levetiracetam had a higher SE cessation rate than valproate and phenytoin as a first or second ASM in benzodiazepine refractory SE. Overall, due to missing RCT studies comparing lacosamide in children to approved ASMs, no recommendation can be made at this point. In our hospital, lacosamide is applied as an ASM in Phase 4. In conclusion, we suggest applying IV levetiracetam or IV fosphenytoin. Alternatively, valproic acid IV or phenobarbital can be used. Treatment of refractory pediatric SE in the hospital intensive care setting, Phase 4, 30 minutes. In approximately 10–40% of children, the first and second-line drugs fail to stop convulsive SE, and the SE is regarded as refractory, RSE. In 7% of children, the SE develops into super-refractory SE, SRSE, where the SE is ongoing after 24H into induction of a pharmacological coma or proceeding after its withdrawal. Both events are highly associated with long-term neurological morbidity and mortality, RSC 1643.5%. Therefore, aggressive treatment of SE at this time point, TH2, is essential to avoid permanent neuronal damage. There is no clear evidence to guide pharmaceutical treatment in this phase. Therefore, treatment is based on case series and expert opinions without controlled trials being available. Additionally, specific treatment for the underlying etiology should be started. See Chapter Pharmacological Considerations in Specific Pediatric SE Subtypes. Most patients are transferred at this point to the intensive care unit to receive further second-line drugs and/or general anesthetic drugs such as thiopental, pentobarbital, midazolam, or propofol, third-line agents, with continuous EEG, CEEG monitoring. There are limited data supporting which third-line ASM to choose and the recommended speed of titration. CEEG is essential to guide the pharmacological coma as well as exclusion of non-convulsive SE, NCSE, or electrographic seizures. It is unclear whether the treatment goal should merely be the termination of seizures or the induction of a burst suppression pattern. In addition, it remains unclear how long a patient should be maintained in a pharmacologic coma. Expert opinion usually opts for 24-48 each of electrographic seizure control prior to a gradual withdrawal of continuous infusions. If seizures continue despite treatment or recur during the weaning period of continuous infusion S, a further trial for an additional 24-48H is usually recommended. In a midazolam-induced coma, dosing usually involves an initial loading dose of 0.2 milligrams per kilogram in a 2 milligrams per minute infusion, followed by an infusion at 0.05, 2 mg/kg/h titrated as needed to achieve clinical and electrographic seizure suppression and/or EEG burst suppression. Pentobarbital is usually initially given at a loading dose of 5 milligrams per kilogram in a 50 milligrams per minute infusion, and a further pulse of 5 milligrams per kilogram at similar 50 milligrams per minute infusion speed can be subsequently administered if needed. This is followed by an infusion at 0.55 mg/kg/h that is titrated as needed to achieve clinical and electrographic seizure suppression and/or EEG burst suppression. If seizures persist with midazolam or pentobarbital, then escalating dosing through additional boluses is needed to rapidly increase levels or terminate seizures. Propofol, up to 5 mg/kg/h, is an additional safe and effective option, but recommended for use only for 24H since it may cause propofol infusion syndrome, PRIS, which is associated with a high mortality rate. Another possibility is the usage of inhalational anesthetics such as isoflurane to terminate an SRSE. While 2 pediatric clinical series reported seizure cessation in 94.4%, there is, unfortunately, a high relapse rate after discontinuing the treatment. Though no RCT trials exist, very high-dose phenobarbital has been reported by several authors as an approach to control RSE. In our hospital, we increase the dose of phenobarbital to escalate plasma levels of 80 UUG/mol. This is in line with previous reports where dosages ranged from 40 to 140 mBL/kg/dd with plasma levels of 3,340 UG/mol. A promising future therapeutic approach in RSE is treatment with the non-competitive NMDA receptor antagonist ketamine or S-ketamine, loading 0.5, 5 milligrams per kilogram, maintenance 1, 10 mg/kg/h. Only a small number of case series exist for such treatment in children. In adults, data on S-ketamine are available from open observational studies with response rates of up to 64%. A prospective study, KETAZA-01, comparing the effectiveness of ketamine to diazepam, thiopental, and propofol in children 1-18 years in RSE is currently being conducted. Additional ASM application, for example phenytoin, valproate, levetiracetam, or topiramate, can be reasonable if these drugs have not been tried, if seizures become less frequent, or if they appear to be fragmenting. Further options including cannabidiol, bexanolone, ketogenic diet, and hypothermia cannot be classified as standard therapy but may become options when other measures fail to cease SEE. In any case of RSE due to structural epilepsy, epilepsy surgery needs to be considered urgently. Pharmacological considerations in specific pediatric SE subtypes. Specific pediatric SE subtypes require specific considerations with respect to pharmacologic treatment. In tonic SE, benzodiazepines should be avoided, and therapy may be initiated with fosphenytoin or phenobarbital or levetiracetam treatment. Absence SE can often be stopped through treatment with clonazepam, phenobarbital, or valproate. In febrile prolonged seizures, the identification of the primary fever source is essential. A lumbar puncture can help diagnose meningoencephalitis and help in decision-making with respect to early antiviral or antibacterial treatment. Early genetic consultation and, if available, rapid whole exome genome sequencing should be initiated if a genetic etiology is suspected to offer individualized treatment options. In patients with unknown or autoimmune etiologies and non-infectious encephalitis, extensive diagnostic workup should be performed. Treatment with IV immunoglobulins, 1-2 g per kilogram, over 3-5 days should be considered after securing sufficient blood and CSF sample specimens for later analysis. As soon as infectious encephalitis has been ruled out, IV corticosteroids, methylprednisolone, 20-30 mg/kg/d for 3-5 days, and plasmapheresis or immunoabsorption need to be considered. Seizures in febrile infection-related epilepsy syndrome, FIRES, are highly difficult to treat and usually remain refractory to standard therapy. Treatment approaches include ASM, ketogenic diet, and pharmacologic coma induction. Given the putative causal role of inflammation in FIRES, immunomodulatory therapies have been initiated, such as IV corticosteroids, IV immunoglobulins, plasma exchange or immunoabsorption, and/or further drug treatment with, for example, tacrolimus, rituximab, cyclophosphamide, and anakinra. Algorithm for pediatric SE, excluding neonates. A. Phase 0, 0 to 5 minutes. 1. Stabilize patient, check ABCDE, and address basic life support. 2. Monitor vital signs, ECG. 3. Establish IV line, check and start diagnostic workup, laboratory parameters, glucose. B. Phase 1, 5 minutes. After 5 minutes, administer a first benzodiazepine. 1. Midazolam, buccal, 3 Marzels -1 Weir, 2.5 milligrams. 1, 5-year, 5 milligrams. 5, 10-year. 7.5 milligrams, 10, 18-year, 10 milligrams. Maximal dosage, 10 milligrams. 2. If not available, give diazepam, rectal, 15 kilograms, 5 milligrams. 15 kilograms, 10 milligrams. C. Phase 2, 5 to 10 minutes. After 5 minutes, administer another benzodiazepine intravenously. 1. Lorazepam 4, 0.1 milligrams per kilogram. If not available, 2. Diazepam 4, 0.2, 0.3 milligrams per kilogram, maximal dosage 4 milligrams. 3. Midazolam 4, 0.1 milligrams per kilogram, maximal dose 10 milligrams. If no IV access could be obtained, consider midazolam IM 0.2, 0.3 milligrams per kilogram, max 5 milligrams, midazolam buccal, or an intraosseous access 5 to 10 milligrams. D. Phase 3, 10, 30 minutes. 1. Evaluate indication of cranial imaging, CT, MRI, and of further diagnostics. 2. Start continuous EEG, but do not delay treatment. 3. Inform intensive care unit. 4. After 10 minutes, another anti-seizure medication should be started intravenously. Choose from the following. 1. Phosphonytoin. I'm full. 20 milligrams PEEK max. 1,500 milligrams, 150 milligrams PEE min. 2. Levetiracetam 4, loading dose 40 to 60 milligrams per kilogram, max. Rate 2, 5 mg/kg/min, max. 4,500 milligrams. 3. Valproic acid IV. 4. Phenobarbital IV. 5. Lacosamide Winefur. E. Phase 4, more than 30 minutes. 1. Move to intensive care unit. A full team should be on board. 2. Intubation, induced therapeutic coma. 3. Continuous EEG monitoring to monitor treatment response. 4. After 30 minutes, induce a pharmacological coma. Choose from the following medications. A. Midazolam and 4, 0.2 milligrams per kilogram. Maintenance, 0.05, 2 mg/kg/HR. B. Propofol of 4, 1 to 2 milligrams per kilogram. Maintenance 1, 5 mg/kg/HR, only for 24 hours. C. Thiopental Y4, 2 to 7 milligrams per kilogram. Maintenance 0.5, 12 mg/kg/HR. E-ketamine 4, 0, 5 to 5 milligrams per kilogram. Maintenance 1, 10 mg/kg/HR.